of Ireland for the opportunity to talk on medication overuse headache, which is a difficult and challenging condition to manage, and it's something that we encounter quite frequently, particularly in the headache clinics, but it's seen very much in the community as well. Now, in terms of medication overuse headache, this is the definition, and it's a headache which occurs on 15 or more days per month in a patient with a pre-existing primary headache disorder and developing as a consequence of regular overuse of acute or symptomatic headache medication on 10 or more or 15 or more days per month, depending on the medication, for more than 3 months. Now, that's quite a long definition, and it's something I'm going to come back to again and again in the talk as I go through the issues pertaining to medication overuse. But that's the absolute definition that we are bound by and address in the terms of trying to manage the condition. It's a condition that was first described back in the 1930s, and it became noticed then with the earlier treatments for migraine, with the ergotamine treatments, which are now kind of obsolete, but still available in the US. And it was noted that patients got headaches associated with the overuse of ergotamines. And that was first recognized in the 1930s. It got written up then about a decade or two later in the 50s by Peters and Horton, who followed a number of cases and published some literature on it. And what they did notice that following the withdrawal of the overused medication, which was ergotamine preparations at the time, the patient's headaches improved. So that was it was a condition that it was aware of, but not widely understood back in those days. As a condition, the definition of it, and it was called a number of different things down through the decades. The term medication overuse headache was first introduced by the International Classification of Headache Disorders in 2004. And they associated with the overuse, particularly of the ergotamine, the old preparations, but also compound analgesics, ordinary analgesics, and triptans. And in accordance with the definition in those times, the patient's headaches and symptoms improved upon withdrawal of these painkillers. And that was the criteria for fully medication overuse headache. So basically any form of painkiller, and you have the exhaustive list here, that would contribute to the or cause medication overuse headache. Now, again, other previous terminologies would have been drug-induced headaches, or ergotamine overuse, which was the first described cases, analgesic overuse associated with compound analgesics, things like paracetamol with caffeine preparations, all of the opioids, which is things like codeine preparations, dihydrocodeine, and all of the opioid preparations. The triptans themselves are implicated also in medication overuse headache. So this was at the cycle of between patients getting their headaches, taking more medication, this contributing to their next headache and increasing frequency of headaches, along with the increased use of medication. And in many ways, there was a transformational effect of patients' migraines in terms of the increase in their frequency. So again, this is the ICHD, International Classification of Headache Disorders, in 2004, associating this with any form of analgesic, either simple analgesics, which would be paracetamol or ibuprofen, compound analgesics with paracetamol, caffeine, codeine, ergotamine, opioids, triptans. So all of these medications are implicated in medication overuse headache. All of the acute drugs that you take with increased frequency is the danger. Now, this is our current definition, and this is the 2018 International Headache Classification Disorder. So again, coming back to it and going through it point by point, it's a headache that's occurring on 15 days per month in a patient with a pre-existing primary headache disorder. And I'll come back to these as well. That means if you've got more than 15 headache days, and many patients that we would see in clinics would have 27, 28, 30 days a month, every single day. It's the regular overuse for at least 3 months of one or more of these list of drugs down here that you take for your acute headache or to get symptomatic relief. So you have the list of medications. Now, we classify it differently in accordance to which medication you're taking. If you're only taking therapies for 10 days per month of this group, which would be particularly the triptans like sumatriptan, zolmitriptan, naratriptan, frovatriptan, or an opioid analgesic such as paracetamol codeine preparations, or the compound analgesics with caffeine in them. If you're taking those medications on only 10 days or more per month and have got headaches for 15 days or more per month, you now have medication overuse headaches. With their simpler analgesics, the day count is actually 15 days or more per month. So these are kind of arbitrary differentiation between which painkillers you take or which acute therapies you take, and the evolution of and the diagnostic criteria for having medication overuse headache. Now, so in terms of medication overuse, you have by definition two headache problems. The medication overuse is what it would become under the classification of a secondary headache disorder. It's against the background of having had a primary headache disorder and evolved in increased frequency and subsequently getting the medication overuse as well. And of the pre-existing headache disorders, by far the commonest is migraine, but any pre-existing benign primary headache disorder can do it or be implicated in medication overuse headache. But less commonly, tension type headaches and also cluster headache patients can develop medication overuse headache, particularly also if they suffer from migraine. And some patients in this classification of new daily persistent headache can actually have medication overuse associated with this disorder from the get-go. So medication overuse headache is a secondary to headache disorder against the background of having had a pre-existing primary headache disorder, particularly migraine. So how common is this? It is common. It affects 1 to 2% of the population. It occurs with a peak prevalence age group of in the age 30 to 50 years of age, more common in women in the ratio of 3 to 4 to every one male. What are the risk factors for developing medication overuse headache? Particularly of the pre-existing headache disorders, migraine represents about 80% of those patients who are at risk of going on to developing chronic migraine with medication overuse headache. The increased likelihood increases as you get older, so in the 30 to 50 age group. So you may have had episodic migraine attacks in your early teens, 20s, 1 to 2 per month. As you get a little bit older, that frequency goes up to 4 to 7 headache days per month. And as you get a little bit older again, you're up into the chronic migraine and chronic daily headache and more than 15 headache days per month. Women at more risk of getting medication overuse headache. Other kind of lifestyle risk factors would be cigarette smoking, physical inactivity, overweight, and psychological conditions such as comorbid anxiety or depression can predispose you to medication overuse headache as well, along with then the regular use of tranquilizers such as benzodiazepine would be another risk. And also this condition can be seen in families. So there is probably some kind of a genetic predisposition to medication overuse headache because it may be a previous generation family member also had medication overuse headache. Now, in terms of medication overuse headache, this is just a schematic view of what's happening over time. So over here on the left, let's say this is a patient in March who would have had, let's say, 4 headache days per month. And over the next few months, their headache frequency went up. And if you count the number of days in that calendar, it's 17 headache days per month. So now she has chronic daily headache. She has a diagnosis of migraine. So she's moving into this chronic migraine group, which is more than 15 headache days per month. And by definition, episodic migraine is the number of headache days you get per month, which is less than, which is 14 or less. So this pattern can transform over time, in that the frequency of these headaches increases insidiously or gradually over a period of time. So they go from migraine to chronic migraine, more than 15 headaches. And you add into that the tendency or the use of acute therapies by individuals in terms of trying to manage the headache days when they occur, whether it's a simple analgesic or specific migraine drugs such as a triptan, or a stronger analgesic such as paracetamol coating preparation. So that's the mix, going from episodic to chronic, in conjunction then with the additional use of acute therapies, and you end up with a medication overuse headache, which, as we said, the definition is more than 15 headache days per month, and along with the use of on 10 days or more of the triptans or the opioid analgesics, or on 15 days the simple analgesics. So that's what happens. So in terms, well, let's talk a little bit about, well, what are these headaches like? You know, obviously we've been defining it up to this point as what the patient has, but what actually is the patient complaining of in terms of their headaches? So again, you go back, what was their pre-existing headache disorder? The most likely one, as I said, is migraine. And so this is your typical migraine headache in terms of the classification, in that patients will typically have an attack that will last for 4 to 72 hours. It's a one-sided headache. It's throbbing, pounding, pulsating. Patients will describe it to being moderate to severe, usually in the range of probably somewhere between 7 and 10. It's worsened by movement. Many of these patients will have nausea and vomiting with their headaches, and intolerance to light or sound. That's your typical migraine attack. You know, if you look at this diagram here, which is just looking at the prevalence or the number of migraine attacks that patients get, the most common, let's say, migraine group would be those patients, let's say, who would get 1 to 2 migraine attacks per month, which is, in this group would recommend would be over 60% of migraine sufferers, let's say, in the community. But as the headache frequency goes up, let's say to 4 to 6 to 7 to 9, the incidence of the number of patients is falling, in the sense that as I said, migraine affects 10 to 12% of the population, but chronic daily headache is about 1 to 2% of the population. So your migraine frequency, or the migraine, and let's say number of patients with increased headache days, goes down, whereas the patient figures are less and less, but the number of days are going up and up. And then patients move as the headache frequency increases, they finally cross the line and they're into chronic migraine. They've got more than 15 headache days per month. What's interesting as well is that patients sometimes oscillate between more than 15 headache days per month and less than 15 headache days per month. And every month is only a snapshot of the patient's calendar, let's say. So they can move between chronic and episodic migraine over a 12-month period based on the natural history of the disease. And it's estimated that of your episodic group, about 3% of those will drift into the chronic migraine group every year. And then others will drift back into the episodic migraine. That's the natural history of what happens between going from episodic to chronic migraine. But your typical migraine attack, let's say, in patients who had a migraine attack, let's say 1 to 2 a month back in, let's say, in their early 20s, was a one-sided headache maybe, or it could be both sides, throbbing, pounding, worsened by movement, nausea, intolerance to light and sound, incapacitating, forcing the patients to lie down. What happens in chronic migraine is that the headache frequency goes up. So you've got up to more than 15 headache days per month. The character of these headaches, on at least 8 days per month of their headache days, the characteristics of the headache maintains the same or similar characteristics as their migraine attacks that they used to get when they were getting them, let's say, 1 to twice a month. So they would still continue to be one-sided, pulsating, aggravated by movement, accompanied by nausea and intolerance to light and sound. Many of these attacks wouldn't be as debilitating as the attacks that they get, let's say, infrequently, let's say in terms of once a month, but they still maintain the core features of the migraine attacks that they were always getting. And so they get headaches on 8 days per month, exactly similar to the migraine attacks they used to get in their earlier days. And on the other 8 days, the headaches can be much more diffuse. They're just there in the background, not as disabling as the specific migraine attacks. but they feel it themselves. They're almost never without a headache. And it's all that, even when the bad headache goes away, they're left with a background headache in the back, in the background, which never actually disappears. And then in conjunction with all of that, of course, these are the chronic migraine patients. They're feeding into the cycle of overuse of medication. They're taking whatever they can to try to control their symptoms, alleviate the symptoms, get pain relief, try to remain functioning. So they get into this cycle of the frequency of their headaches and the continued use of whatever painkiller they're taking, whether, as I said, it's a prescribed medication such as a triptan, or an opioid, or over-the-counter preparations such as in some of the codeine preparations, or the anti-inflammatory type medications. So that's the problem, and that's basically typical kind of chronic migraine with medication overuse picture, which can be very challenging to address. Now, the other question is, if you're using, if you're an episodic migraine patient and you get, 4 or 5 headache days per month, and I start using, the sumatriptans, the imigrans, the zolmitriptans, the frovatriptans, what's the risk, or what's the likelihood? How long is this going to be before I could end up with medication overuse headache? And it's felt that if you start overusing the triptans gradually and insidiously, which would be on more than 10 days per month, then you could end up having chronic migraine with medication overuse headache in about 1.7 years. So the RGOT preparations are kind of obsolete, but it used to be about 2.7 years. And just with simple analgesics like paracetamol or ibuprofen, you can have medication overuse within 5 years. I don't have a figure for the actual opioid analgesics, but it would probably be very comparable, or if not even sooner than the use of triptans. So in terms of, what's going on in migraine, what's happening, why am I getting these headaches? Why, what is the explanation for all these symptoms? So if you go back to the, what we call the trigeminal vascular theory of migraine, which is a patient, let's say, who gets an attack once a month or once every few weeks, your pain sensitive structure are the coverings, let's say, on the brain, which are called the meninges, and the blood vessels within those spaces called the meningeal blood vessels, and the meninges themselves. So they're your pain sensitive structures. The pathways for pain are along a nerve that we call the trigeminal nerve, and they take painful messages into the brain itself. And this is kind of the engine room of the brain where things are processed. So what happens during a migraine attack, whether it's on exposure to a trigger factor or your threshold for migraine, you're getting the release of specific chemicals from the peripheral end, let's say, which is out here on the coverings of the brain. You're getting the release of what we call chemicals or neuropeptides, particularly this one here, CGRP, but also other ones, substance P, neurokinin. And the release of those, what we call neuropeptides, causes a local kind of inflammatory reaction around the blood vessels, such as the meningeal blood vessel, as it would be here in this diagram. And that causes a kind of what we call a local inflammatory response. And that in itself, and it becomes swollen, and that in itself triggers and stimulates a painful pathway along in the same nerve, the trigeminal nerve, along here. So this is a painful pathway. And in here, in what we call the brainstem, this incoming painful information is processed, and then it's sent up to higher centers in the brain, which is how we perceive pain. And this diagram is just showing the same thing. So the painful information coming from the blood vessel is transmitted in along what we call the trigeminal nerve. In here, it's processed within the brainstem, and then you get further pain transmission signals up into the higher centers where we perceive pain. So that's what's happened, let's say, when you have a migraine attack, which, as I said, occurs once a month or whatever, and you take something like a simple painkiller, or you take a stronger specific anti-migraine drug, such as sumatriptan or or zolmitriptan. And for those for whom it works, it just shuts down this pathway, and you get relief of your symptoms, within an hour or within 2 hours, hopefully. And that happens for quite a lot of people. So that's a migraine attack, and that's how we generally would manage it. So that's the episodic migraine attack. So you move forward, and what's happening? What has happened? How come I'm now getting, 15 headache days per month, or 25, 26 headache days per month? They all sound like migraine attacks. So what's happening is that you're getting a change in what we feel is in what we call the physiological, the normal processing of this pathway of pain that's being transmitted from let's say the meningeal blood vessel or the meninges. So you're getting also increased activity of these chemicals that were being released, such as CGRP. So you get persistent activation of this trigeminal pathway. So you get persistent transmission of painful signals coming in from the periphery, from the meninges, from the blood vessels, giving rise to a constant chronic daily pain, which never switches off. So you're getting this, what we call upregulation of vasoactive mediators, transmitting and triggering painful pathways. And even when you get in here then into the brain, where pain is processed, it's also felt that you're getting a decrease in the inhibition of pathways. Because when we get pain, if you feel pain, when your pain perceives it, it tries to control the pain, and there are natural pathways of controlling pain, particularly migraine. So there's this thing called here, the PAG, which is periaquedural gray matter. You get natural painful inhibitory pathways coming down here, trying to block the incoming painful signal that was coming from the blood vessels. It's felt that this is becoming dysregulated. It's becoming ineffective. So the painful pain pathways that are coming in here are not being blocked in the brainstem. So you're getting an increased transmission up to the higher centers where we perceive pain, and that's what we call sensitization. So again, you're getting more vulnerable and susceptible to the incoming painful pathways. And what contributes to this is felt that the overuse of analgesics is facilitating the potential for increased excitability of neurons and the increased transmission, ultimately, of pain pathways where we perceive pain in the higher centers. And you also get what we call an expansion of what we call the painful field, so that a localized headache that you used to get in the past can now become much more generalized and affect the whole head, so that the whole painful structure is becoming more sensitive in terms of the pathway. And that's what we feel is going on in chronic migraine. And then with medication overuse, all of this process is being facilitated. So that's what we're trying to deal with. And how do you try to manage that? So that's the challenge. That's what we see a lot of patients in the headache clinic with medication overuse headache and chronic migraine. And it's a dual diagnosis. You have to deal with both aspects of it. And traditionally, it's felt you only had medication overuse headache if upon withdrawal of the overuse medications, the patient's headaches got better. That definition is, I think, kind of being looked at, and because it doesn't always follow that if you stop taking the medication that your headaches will go away. And then it's felt that you have chronic migraine specifically, rather than chronic migraine with medication overuse headache. So in terms of this condition itself, what's the first thing to get out there and to focus on is education and prevention. I think, and this is why, for example, the Migraine Association is a tremendous asset to the public, because they will be very much aware of what I'm talking about. And when patients ring for information, this is one of the very important issues that patients get educated on. And particularly because, headache by its how common a condition it is, it's something that everybody self-medicates on, on a regular basis. So it's very important to be aware of the dangers of self-medicating for headaches and the risks of going on to develop medication overuse headache. And education and prevention goes a long way to stop this from occurring in the first place if you're aware of the risks of increasing the use of any form of painkiller, be it over the counter or prescribed. Going to look at these other headings now in a second as well: drug withdrawal, preventative therapies, acute therapies, etc. Now, education and prevention is what I've just been talking about there, but I cannot emphasize it so much as that anybody who self-medicates needs to be fully aware, particularly in the management of their headaches, of the risks of this condition, because it is common. It affects 1 to 2% of the population, which is still a very common disorder. Now, it's also important, of course, and then through forums like this and in lots of different seminars, that, you know, we have meetings with pharmacists and GPs, because in essence, the management of headache, medication overuse headache and chronic, is primarily probably a primary care condition, and because it's so common that people need to be able to go to their GP or their pharmacist and get good advice, and made aware of the dangers of medication overuse, made aware of the options in trying to manage, etc. And therefore, again, we use an awful lot of education tools in community pharmacies and general practice. We did a study ourselves a few years ago in the community pharmacies looking at the use of medication for the management of headache. And it's interesting, and I just take this slide to demonstrate, you know, when patients who suffer from particularly migraine, which medication was their preferred option. And it's interesting that quite clearly the triptans and the compound opioid analgesics of paracetamol, codeine, and ibuprofen, you know, were the ones where the medications that patients preferred far in excess of the simple analgesics such as paracetamol or ibuprofen on its own. Again, that in itself is just highlighting how common the problem is, highlights again the risks associated with using these medications without knowing the risks associated with them. I'm not saying these medications shouldn't be used, but obviously they need to be used appropriately, and patients should try to restrict and limit their use of acute therapies for headache to 2 to 3 days a week max, and that limits the likelihood of going on to develop medication overuse headache. It then looks at, you know, what's the option in terms of medication overuse headache in terms of abrupt withdrawal of medications versus gradual. Now, the challenges there are, it's not so easy to do an abrupt withdrawal of patients who are using, you know, strong narcotic analgesics, because the danger is, or if they're also using drugs like benzodiazepines for anxiety, because of the risk of going through significant withdrawal symptoms such as nausea, even vomiting, generalized aches and pains, increased anxiety, generally feeling unwell and miserable. So they're going through withdrawal syndrome. And if you try to just abruptly withdraw those type of analgesics, then you know, that they can experience withdrawal symptoms for 7 to 10 days. So it's going to be very hard to achieve the goal there. So it's really a gradual withdrawal of those type of medications. There are, however, with other acute therapies which are causing medications such as the triptans, simple analgesics or NSAIDs, we recommend you just go cold turkey and a complete abrupt withdrawal and stop taking those medications day one. And that can be an extremely successful outcome for many patients. And that's the challenge in terms of how do you, with the aid of a diary, of course, manage these patients over time, because obviously the patients need to change their whole approach to managing headaches by being told that you shouldn't be taking any acute therapies, or at least limiting it to only a number of days per week. Now, there was a study done in terms of detoxification, in terms of the brief intervention for medicine, and this showed that with it combined with advice, and this is before we talk about using any acute therapies, you know, when patients are explained about what's going on in terms of medication overuse headache, the dangers, and how these acute therapies are contributing to their headache number of days, and their general disability around headaches. And when it's explained that if you stop, because you've got medication overuse headache, and you stop taking the medication and you monitor everything with the diary, and the diaries are so important because, you know, every week is different. And you're looking for, and it's only with the accuracy of a headache diary can you, let's say, objectively evaluate, you know, how you're doing over a month or 2 months or 3 months period. And you need to do that evaluation over a period of time, not over a period of days. It needs to be over 2 to 3 months. And this was a brief intervention study which was done in Germany. And after 3 months, they had demonstrated that there was a reduction of over 7 days per month from their chronic migraine picture, which is a very successful way of managing. This is before we even talk about medications. And the chronic headache resolved in 50%, and that they were now getting back to their episodic pattern. And this was reproduced, and it's that after 6 months, they still had a significant reduction in the number of headache days per month they were getting. And that was just through educational programs and making patients aware of what was happening with the overuse of headaches and overuse of medication and how it was happening. Historically, of course, it was felt that patients were meant to be detoxified, by which I mean they need to stop taking their painkillers before a preventative drug will be introduced. And the goal of a preventative drug is to reduce the frequency in which headaches are occurring, but also reduce the frequency of which they're taking medications, and ultimately, of course, to improve the quality of life for the patient. And our traditional preventative therapies are amitriptyline, beginning at a low dose, or other conventional kind of migraine preventative therapies would be beta blockers, propranolol, metoprolol, atenolol, and topiramate. All of these medications, preventative drugs, are used for chronic migraine and medication overuse headache. We expect with any one of these in a successful outcome to get at least a 50% reduction in the number of headache days patients experience, and we get an outcome of about 50% with response to these medications. Candesartan is another preventative drug. So the outcome in that, how successful are we managing migraine and chronic daily headache and medication overuse headache with our conventional preventative drugs? So we do succeed. It's a successful withdrawal at about 50% of 70%, which is maintained after 12 months. It is important to be aware that these very patients who have had medication overuse headache, they remain an at-risk group for relapse over the next 6 years. And about 40 to 50% will relapse into medication overuse of headache. Again, the risk factors being for relapse will be, again, a relatively high use of acute therapies, again, lifestyle things such as smoking, alcohol consumption, and psychological problems such as low self-esteem. So these would be the risk factors for relapse in patients who have achieved a successful program in terms of withdrawal from medication overuse headache. So let's bring us right up to 2021, and we're living in fast changing times in terms of migraine and its management of chronic migraine and medication overuse headache. We have a lot of experience in recent years with the advent of the CGRP monoclonal antibodies, and these are specific preventative therapies for migraine, and their potential, what we call game changers. Now, just in essence, what these are, CGRP, I've mentioned it in some previous slides. This is the chemical that's released from the peripheral end of a nerve, which is responsible for causing, the inflammation and the expansion of a blood vessel in the brain, such as in the region of the coverings of the brain, giving rise to painful transmission. Comes in along the pathways for pain pathways, and we get headache. The CGRP monoclonal antibodies are drugs that have been developed to block these the actions of these molecules. They're preventative drugs, and they're preventative drugs because they have what we call a long half-life. They stay in your body for at least a month or two. They're given by injection once a month. And the goal of these drugs is to bring about a reduction in the frequency of attacks, a reduction in the severity of attacks, make you less reliant on the use of acute therapies. And as I said, obviously improve your quality of life. So as an individual, you're back living a healthy life. In Ireland, we have two of these medications that are currently available, erenumab and fremanezumab, and galcanezumab is another one that will probably become available. So these are the new drugs that are out there, and many of the listeners, some of you might be on them, and many of you will have heard of them. So again, how do they work? Okay, just coming back, this is a slide that I showed earlier. This is, let's say, what we call your nerve supply. This will be the blood vessel in the coverings of the brain and what we call the meningeal blood vessel. During a migraine attack, you get a release of this chemical up here, the CGRP, other chemicals as well. That causes a local effect on the blood vessel, giving rise to becoming inflamed, expanded, and painful. And you get the transmission of pain in through this trigeminal nerve. It's processed in the brainstem, and then you get further transmission of the painful pathway up to the higher centers. This is a blow up. This slide here is a blow up of this area here. So this would be the nerve. It releases CGRP into this area here. The CRGP then has an affinity for receptors on the blood vessels. And when you get this CGRP on the blood vessels, it gives rise to what I said, the expansion, inflammation, and the stimulation of painful pathways. Now, what do the monoclonal antibodies do? Again, just to orientate you, this is the nerve, like this area here. This is the nerve. You get the release of these chemicals, which is the CGRP. And these drugs, the fremanezumab and the erenumab, they're both CGRP monoclonal antibodies, but they work differently. The fremanezumab attaches itself, which is this kind of Y-shaped structure here, that attaches itself to the CGRP here in this space, thereby blocking the actions of CGRP at that level. The other drug, erenumab, attaches itself to what we call the CGRP receptor on the blood vessel. So the erenumab attaches itself here, and in that way blocks the actions of CGRP. And when these drugs, so what do they do then is that they're blocking the actions of CGRP, which is a key, what we call neuropeptide, responsible for the activation of what we call the trigeminal vascular theory, and also severely implicated in the origins of a migraine attack. And by blocking the actions of CGRP, you can prevent migraine from occurring. And of course, when you look at the data, well, we see how successful are we at managing these attacks. And of course, what is very interesting in relation to these drugs, and this is a very pivotal article that was published by actually one of your speakers there last week, Dr. Tepper. And they looked at erenumab in patients with chronic migraine with medication overuse headache. Traditionally, when we did studies with chronic migraine, we excluded patients with medication overuse in the trials because we felt it might disrupt the results too much and not get a true picture of the efficacy of the drug. But in these studies, patients who had chronic migraine and also had medication overuse, they were included in these trials. And traditionally in the past, before patients would be started on a preventative drug, they would have needed to stop their use of their acute therapies. But that wasn't the case in these trials. They were taking their medication and they were started on these preventative monoclonal antibodies. And the results are quite dramatic. And this is looking at the erenumab one, okay? Without getting into the details of the slide, but what it is telling you is that you were getting a significant reduction in the number of headache days per month within a month of taking the erenumab, which, as I said earlier, is given by an injection once a month subcutaneously. And not only that, but you were seeing significant reduction in the frequency of their headache days within a week in many patients by the use of these drugs. And that's including those patients who are actually had medication overuse headache as well and had been using a lot of acute therapies. Now, again, and then just to just to recap, well, what's going on here? Well, this is your famous nerve again, the trigeminal nerve, which is the pain nerve that's responsible for pain. It's releasing this orange stuff is the CGRP, and this is your drug. This is the monoclonal antibody here. This would be the equivalent of Erenumab. So this is blocking what this CGRP here, it wants to attach itself here, as you see here, to the receptor, and that's what's giving rise to your migraine attack. But with the monoclonal antibody, it prevents the CGRP from getting to the receptor and thereby preventing migraine attacks from occurring. And these results are dramatically good. And in clinical practice, we see some outstanding results, with these medications. Not to be outdone, Fremanezumab, which is the other monoclonal antibody that's available, also had a very similar study in terms of patients with chronic migraine and medication overuse headache. And what they did is that they also showed a dramatic reduction, similar to Erenumab, in the reduction of the number of headache days per month, going from a chronic migraine picture back into an episodic form. And also with both Erenumab and Fremanezumab, when they started using these drugs, they also started using their acute therapies less and less, meaning they were using their codeine preparations or their triptans less and less. So by virtue of the efficacy and the effectiveness of their preventative drug, they found that they didn't need to use their acute therapies anymore for their headaches, or to a much lesser extent. And just to recap again, what's happening, this is the trigeminal nerve, this is your CGRP, and whereas the Erenumab works here, this drug, Fremanezumab, is working here in this space between the nerve and the blood vessel, and it mops up the CGRP here. And in that way, this drug prevents the CGRP actions by mopping it up here. And both drugs are very effective and have really become potential game changers in terms of how we manage both chronic migraine and medication overuse headache. It's very hard to talk about a migraine, give any talk about migraine and chronic migraine without mentioning botulinum and Botox, because there's an awful lot of interest in the role of Botox, and we get a lot of questions about it. It is used, and again, it has a benefit. It works completely differently. The other thing I should say about the Erenumab and the monoclonal antibodies, they're specifically developed and designed to treat migraine. All the other medications we see and use are known to help migraine patients, but they were never developed to treat migraine as such. And that goes with Botox as well. It works differently though, and it's felt to work by what we call an anticholinergic effect, by virtue of when you give the injections, it blocks transmission of pain that way and also prevents migraine in many patients. Now, it's administered subcutaneously. You have to give it into 31 sites in your head, basically in the frontal regions, the temples, the back of the head, and the neck, and the 31 injection sites, and it's given at 3 monthly intervals. And again, the results are quite good. And this is a study, again, that was done a number of years ago. This is what we call the preempt studies. And this was showing that the average age of these patients were 41. Most of them were women. They had over 19 headache days per month. They had most of them had tried previous preventative drugs. They were using a lot of overuse medications, over 65% of them, and they had a lot of disability. And again, you were seeing quite a significant reduction in the number of headache days after 4 weeks, and that was sustained after 24 weeks. So it certainly has a benefit in a cohort of patients. So it is an option as well for both migraine prevention and medication overuse headache. So where are we going though? Where's the future? And as I said, we're living in a fascinating time. So there is another group of CGRP antagonists emerging, and they're what they call small molecules. Now, the difference between a small molecule CGRP and what they call the monoclonal antibodies, the big molecule CGRP, is that, number one, the monoclonal antibodies have a very long half-life. They're given by injection once a month. And also, they don't cross a thing called the blood-brain barrier because they're too big. So they're working on what we call the periphery out here on the coverings of the brain and the blood vessels. Now, there's a group of small molecules called GPANs, and they're small molecule CGRP antagonists, and again, they all have great names. There's atogepant, rimegepant, and urogepant. Now, two of these small molecule CGRP antagonists are being developed for migraine prevention, and one has been developed, obrogepant, is for the acute treatment of a migraine attack. Now, they're also what we call antagonists to CGRP, and they're antagonists at the receptor site here. This is the blood vessel. So they attach, these small molecules, they attach themselves to the receptor site of the CGRP on a blood vessel, and in that way they work and help migraine prevention. Now, the interesting thing though is that they may work both as an acute therapy and as a preventative therapy. So that really is a kind of a seismic change in the potential thinking for migraine management. And the thing about them is that these are tablet formulations, of course, in the same way as you take any medication. So these are tablets that you would take either once a day or twice a day, depending on which formulation it is. And you can use them as a preventative therapy. And the data currently, and there isn't as much data out there compared to the monoclonal antibodies, but they are demonstrating very good efficacy as well in terms of the reduction in the frequency of headache days per month. And other groups, and another member of that group, the obrogepant, is also used as an acute therapy option. For example, when you do get an acute attack, so that will be an option, let's say, to treat an attack, and you can compare the efficacy of that, which may be your traditional therapy, whether it's sumatriptan or zolmitriptan or paracetamol, but they will be directly challenging what we call the traditional migraine preventative therapies of the triptans. And there will be lots of debate as to, are they as good as the triptans? What kind of an alternative option are they? They certainly will be an alternative option for patients who can't tolerate or is contraindicated in the triptans. But in terms of preventative drugs, atogepant and rimegepant will be very interesting alternatives to the use of monoclonal antibodies going forward. So in terms of migraine, where's the holy grail of migraine medications? I think certainly we're not there yet, but we're in a completely different set of circumstances than we were 5 years ago in terms of migraine management. And I think undoubtedly, the International Headache Society, all the different teaching bodies will be moving their guidelines and changing their guidelines because of the increased options in terms of particularly chronic migraine management and medication overuse headache management with the advent. And I would say at this point, with the known benefits of the monoclonal antibodies such as fremanezumab and erenumab, and also what's going to be the role for the small molecules, GPANs, when they become more widely available, both as preventative drugs and as acute therapies. It's a very exciting time, for people like me as physicians to have new options and real options as well in terms of new therapies to manage both acute migraine, chronic migraine, and medication overuse headache. And obviously, of course, and most importantly of all, times are getting better in terms of the options for patients who have very debilitating attacks of migraine and suffer from the most debilitating form of migraine, which would be chronic migraine with medication overuse headache. And that completes the talk. Thanks very much.